have a great team in our SIG right now. So I'm happy to introduce Laurentiu now. He's a gynecologist with interest in fertility, early pregnancy, and of course miscarriage, and has undertaken a PhD investigating endometrial receptivity in the context of recurrent miscarriages at Tommy's National Center for Miscarriage in Birmingham. We heard Jan Brosens this morning from, and I pass the ball to Laurentiu, and we are going to have a nice talk, Laurentiu.
It is a pleasure to contribute with a lecture following my previous speakers in this ESHRE pre-congress course. I will give you an overview of the current tests and markers of endometrial receptivity. The focus will be on clinical relevance, less so on the basic science. I have no conflicts of interest. I will start with some background information on endometrial receptivity. What is it and how to investigate it in the context of research? We will continue with markers of receptivity investigated by ultrasound, endometrial biopsy or endometrial fluid aspirate, and hysteroscopy. Then we will conclude with a take-home message to summarize the topic. Endometrial receptivity has a very broad definition. It represents the intrinsic function of the endometrium that enables it to provide an optimal environment for embryo development and placental formation. You can't really talk about endometrial receptivity without mentioning the window of implantation. This is a narrow time frame with maximal endometrial receptivity surrounded by refractory endometrial status. Conventionally, it was believed to span over 4 to 5 days in the mid-luteal phase, but recent molecular studies propose to narrow it down to only 30 to 36 hours. Do we think endometrial receptivity is important? Opinions are split on this question. We know that embryos account for 1/3 of implantation failures, while impaired endometrial receptivity and suboptimal embryo-endometrial crosstalk are responsible for the remaining 2/3. Based on this information, I would say endometrial receptivity is important. We have already heard Professor Brosens speak about endometrial selectivity, the complementary concept that enables the endometrium to function as a biosensor of embryo quality. This is a summary figure describing the fate of an embryo based on its quality. A high-quality embryo should be nurtured by endometrial receptivity and lead to a successful pregnancy. Suboptimal receptivity would lead to implantation failure in this context. On the contrary, a poor quality embryo should be denied implantation by endometrial selectivity to preserve the maternal resources. Suboptimal selectivity would lead to the early miscarriage of an aneuploid embryo. All the theory sounds interesting, but what do we want from the practical point of view? Ideally, we would like a test to measure a marker that can inform us whether the endometrium is adequate or not. In simple terms, this should guide us to perform the embryo transfer with a good chance of success or not. That's all. IVF is the main context, but it could also apply to IUI or natural conceptions. Now let's look at how to research the markers of endometrial receptivity in the context of IVF. We should start with a cohort of women undergoing IVF, and we should apply a test assessing the endometrium sometime before the embryo transfer. Women would then undergo embryo transfer, have a pregnancy test, and follow up for the pregnancy outcome. Based on this outcome, which is either success or failure, we can then look back to see if the marker we measured before the embryo transfer made any difference to the outcome. It is really important to stick to this chronology of events because measuring the endometrial receptivity marker after the outcome is known could lead to significant bias. We will not know if the marker has a particular value because of the outcome or the other way around, similar to the chicken and the egg, which was the first one. I will come back to this idea with a clear example later on. The following slides are based on a recent comprehensive systematic review we have published in Human Reproduction Update with additional input from the latest research where it became available in the meantime. There is an exponential increase in the number of publications related to endometrial receptivity, and this graphic is the output from PubMed when searching for endometrial receptivity. Our review included 163 studies and identified over 50 markers of endometrial receptivity, investigated predominantly in the context of IVF by looking at their ability to predict clinical pregnancy. Ultrasound was by far the most popular test used to measure a variety of markers of endometrial receptivity. They can be split in markers of mass, such as endometrial thickness and volume, markers of vascularity, represented by various Doppler indexes, and markers of appearances, such as triple line pattern and wave-like activity. These markers were measured at various points throughout the IVF treatment, including before and during controlled ovarian stimulation, on the day of HCG triggering, on the day of oocyte collection, and on the day of the embryo transfer. Endometrial thickness must be the first marker that comes to everyone's mind when they think about evaluating the quality of the endometrium, and this was reflected in the multitude of studies investigating it. It is usually measured by transvaginal ultrasound in the sagittal plane, from one basal surface to the other without including any myometrium. It is quick, cheap, and easy to measure, but is it useful? Again, we are focusing on IVF, but the results of all the markers are very similar between IUI and IVF. This is where we start digging into the data. The first type of studies we looked at were those that reported mean endometrial thickness in relation to clinical pregnancy. In fresh embryo transfer, the mean endometrial thickness was different between pregnant and non-pregnant women when measured on the day of the HCG injection and the day of embryo transfer. However, the difference was very small, with a point estimate less than 0.5 millimeter. This is important because we know there is variability in measurements, and 0.5 millimeter doesn't really mean anything clinically. A similar difference was seen in non-fresh embryo transfer, when the endometrial thickness was measured on the day of the commencing of progesterone treatment. Then we looked at studies that provided data for every cutoff ranging from 6 mm to 17 mm endometrial thickness. The analysis compared women who had less versus more in relation to each particular cutoff. A total of 19 studies were included in meta-analysis, and every cutoff had data for a large number of cycles, up to 42,000 cycles, which increases the precision of estimates. The measurements were taken on the day of the HCG injection, and data is relevant for fresh cycles. This forest plot displays the association for every cutoff, again, less of the cutoff versus more of the cutoff. We can see that thicker endometrium is better for every cutoff, with the largest difference for thin cutoffs of 6, 7, or 8 millimeters, and less significant difference for higher cutoffs. What does it mean in practical terms? Women who have an endometrial thickness of less than, say, 6 millimeters are less likely to have a clinical pregnancy compared to those who have a thickness higher than 6 millimeters. Same goes for 7 millimeters, 8 millimeters, and so on until 17 millimeters. The more the better for every cutoff. Data from the previous slide are all very exciting. It means endometrial thickness is associated with the pregnancy outcome. So we have a cheap and easy test with potential, but now let's see how accurate it is in predicting the fate of an embryo transfer. Can it guide our decisions whether to perform the embryo transfer or not? This is the graphic of accuracy based on every endometrial thickness cutoff. In practical terms, a complete disappointment. The accuracy of endometrial thickness overall is 0.57, just slightly more than tossing a coin and making an important decision based on that. When we look in more detail, we can see that the 6 mm cutoff has the highest sensitivity of almost 100%, but the specificity is less than 1%. This means that it is very unlikely to have a clinical pregnancy following an embryo transfer with an endometrial thickness less than 6 millimeters, so it is more of a marker of endometrial non-receptivity. We can't predict the fate of a transfer if the thickness is more than 6 millimeters. How often do we see a thickness of less than 6 millimeters in clinic, almost never. On the opposite side is a cutoff of 14 millimeters that has a low sensitivity of only 9%, but a high specificity of over 90%. Again, useless in guiding us what to do with the embryo transfer. When the 3D scanners became available, we started to measure the endometrial volume in the hope that it might be more accurate than endometrial thickness. Studies investigated associations between endometrial volumes on the day of the HCG injection or the day of the embryo transfer, but overall there was no association with the outcome of the embryo transfer. 3 studies looked a bit deeper into the data and tried to establish various cutoffs for endometrial volume. These were 2 and 4 milliliters on the day of the HCG injection, 2 and 2.5 milliliters on the day of the fresh embryo transfer, and 3.2 milliliters on the day of the frozen embryo transfer. Similar to endometrial thickness, endometrial volume has no ability to discriminate between reproductive success or failure. This is where we become even more technical. Researchers started measuring various Doppler signals based on the assumption that the more vascularized the tissue is, the healthier it is. So in relation to endometrial receptivity, we measured Doppler signals in the uterine arteries, in the subendometrial space, and within the endometrium itself. The more advanced the scanner machine is, the more signals it allows you to measure, so you can imagine the range of data reported in the literature. One downside of vascularity measuring is that there is no standardized way to do it, so it is very operator dependent. I have presented here data for the most commonly used markers of vascularity for both endometrium and subendometrial space as measured on the day of the HCG injection. VI stands for vascularity index, FI stands for the flow index, and VFI stands for vascularization flow index. They all measure how well the tissue is perfused. There was no association between endometrial perfusion and pregnancy outcome, but there was a degree of association between subendometrial space perfusion and clinical pregnancy, mainly for vascularity index and flow index. What this means in practical terms is that vascularity of the endometrium is important, but we do not have any cutoffs that can guide us clinically whether to perform an embryo transfer or not. So really, it is not that useful. Endometrial pattern is probably the most popular marker of endometrial receptivity after endometrial thickness. It relates to the triple line appearance of the endometrium, and it is generally believed to be a positive finding. But then again, when we look at the real numerical data, endometrial pattern disappoints as much as the previous markers. There is no association between endometrial pattern and clinical pregnancy in IVF. When it comes to the accuracy of predicting clinical pregnancy, the triple line appearance has moderate sensitivity and low specificity when assessed on both the day of the HCG injection or the day of the embryo transfer. In practical terms, the endometrial pattern is irrelevant because it can't guide clinical decisions. We can stop worrying about it, first because it's very subjective, and second because it can't predict the outcome. We are now going to a full new chapter of endometrial receptivity testing, a chapter that combines the old and the modern. For historical reasons, I am mentioning the Noyes criteria of dating the endometrium, as he was the first one to describe the histological changes based on the phase of the menstrual cycle in the 1950s. Very few studies investigated histological dating and subsequent pregnancy outcomes. It has very limited clinical use in relation to fertility. Pinopodes are mushroom-shaped folds in the endometrial structure, and they are visible using electron microscopy. They are considered a positive finding in relation to receptivity, but they expand well beyond the window of implantation. They do not have any clinical use, but studies have not stopped investigating them yet. Uterine natural chiral cells have remained the ugly duck of endometrial receptivity testing for several reasons. First, They have a deceiving name suggesting they are responsible for attacking and destroying the embryo, when in fact they have multiple positive roles for the pregnancy. Second, there is important methodological bias in the way they have become relevant for endometrial receptivity, and I will explain more in the next slide. Third, there is a lack of standardization in their counting and reporting, which makes interpretation difficult or impossible. Fourth and fifth, their testing is expensive and leads to unproven and potentially dangerous empirical treatments with broad-acting steroids. The typical study investigating the role of uterine natural killer cells starts from a cohort of women who suffered reproductive failure by either recurrent implantation failure or recurrent miscarriages. Once they are diagnosed as such, women undergo endometrial biopsy with uterine natural killer testing, and the results are compared to those of women who have not suffered reproductive failure. The control group may include women who have had successful natural conception not suffering from infertility, or women who had successful IVF treatments. I will call this subsequent testing because the testing happens subsequently after completing the IVF treatment or the pregnancy. On the opposite side stands prospective testing, where you apply a test and prospectively follow up the reproductive outcomes after that. It is really important to understand the difference between these two concepts. The subsequent testing after completion of the pregnancy completely ignores the effect of the pregnancy on the uterus and endometrium. Here is an example to understand the massive bias this methodological approach has. Say that instead of uterine natural killer cells, you wanted to investigate the relation between the size of the uterus and the pregnancy outcome. And there are two ways to look at it. First one, you compare women who suffered first trimester miscarriage with women who achieved live birth at term by comparing their uterine size 2 weeks after the completion of the pregnancy. Unsurprisingly, the results will show that women who suffered miscarriage had a normal-sized uterus, while those who achieved a live birth had a bulky uterus 2 weeks after delivery. Will you ever consider that normal-sized uterus is a risk factor for miscarriage, while the bulky uterus increases the chance of a live birth? I hope not, because the difference in size is caused by the pregnancy itself. Poor study design leads to misleading results. The correct design would be looking at a cohort of women, measuring their uterus and following up their future pregnancy to assess for any associations. Why are we not doing the same for uterine natural killer cells? Pregnancy and miscarriage influence more than the uterine size. Well, in fact, there were 3 studies employing the non-biased approach. First one was published in 1999 and included 22 women who suffered 3 or more recurrent miscarriages. They had various uterine natural killer cells counted, and their future pregnancy was followed up. Out of 15 women who conceived, 4 suffered another miscarriage, and 11 achieved a live birth. The study reported higher counts for some uterine natural killer cells and no difference in others. The second study, published in 2002, included 17 women with 2 or more miscarriages. After undergoing uterine natural killer cells testing, 6 suffered another miscarriage and 11 achieved a live birth. There was no difference in their uterine natural killer cells as tested before the pregnancies. This means the uterine natural killer cells counts could not predict the outcome of the pregnancy. The third and the largest study was published in 2007 and included 87 women who suffered 3 or more recurrent miscarriages. After uterine natural killer cells testing, 19 suffered another miscarriage and 32 achieved a live birth. There was no difference in the uterine natural killer cells as tested before the pregnancy. More than that, if you look at the range of uterine natural killer cells in women who had a live birth, you see that it goes much higher than in those who suffered a miscarriage. This is all the evidence linking uterine natural killer cells with pregnancy outcomes in a prospective way. Why do we believe they are detrimental? Why are we offering empirical treatments that have no proven benefits? A variety of independent molecular markers have been measured in endometrial biopsies and endometrial fluid aspirates. While some have shown promising results in isolated small studies, none of the markers are supported by strong enough evidence to be used in clinical practice, and I'm not going to get into more details on that. We have finally reached the chapter of modern molecular tests that do not focus on single molecules. You might be familiar with the ESHRE test provided by iGenomics, but 6 newer commercial tests have entered the market more recently. The theory behind all these 7 complex molecular tests of endometrial receptivity is that the embryo development might be out of sync with the endometrial development. In other words, the time when embryos are ready to implant may be different from the time the endometrium reaches the highest receptivity. The tests aim to identify this discrepancy by analyzing the molecular profile of the endometrium in a simulated cycle and use the results to guide the future embryo transfer. It assumes the asynchrony is identical from one cycle to another. I am focusing on the ESHRE test because it is the oldest and has progressed the furthest on the evidence scale. ESHRE test has first been published in a peer-reviewed journal in 2011 when it reported receptivity profiles based on 238 genes analyzed. Since then, the technology has progressed from microarray to next-generation sequencing, and the test claims to be able to identify 4 different endometrial phases, from proliferative to pre-receptive, receptive, and post-receptive. It was initially proposed for women who suffered recurrent implantation failure, but the current marketing approach aims to target all IVF cycles. Several observational studies reported results since the beginning of commercialization in 2011. The typical design is a cohort of women diagnosed with recurrent implantation failure, who subsequently undergo ESHRE testing and personalized embryo transfer based on the result of the ESHRE testing. Various rates of success are reported. However, the important missing information is what happens if you were to perform an embryo transfer when the ESHRE test deems the endometrium as non-receptive. Is it really non-receptive? Are you really saving some potentially compromised embryo transfers? No data were published in the peer-reviewed journals. The right side of the screen displays a summary of the most relevant piece of evidence that comes from a randomized controlled trial published last year. I must say this publication has triggered a list of commentaries and critique to both the biology and the methodology behind the trial. The trial included 458 women who were randomized to undergo either ESHRE testing and personalized embryo transfer, or fresh embryo transfer, or conventional frozen embryo transfer. The protocol aimed to include 2,442 women in 5 study arms. There were similar outcomes between the study arms by intention to treat analysis. The cumulative pregnancy rate was higher in the ESHRE group, but this outcome was not pre-specified in the protocol. Per protocol analysis reported higher live birth and pregnancy rates after the first embryo transfer in the ESHRE group. Given the amount of critique and deviation from the pre-specified protocol, in addition to the study being conducted by the group marketing the ESHRE test, I believe that a third-party, independent group should conduct a less controversial trial before definitive conclusions can be drawn. I am mentioning hysteroscopy as the last test for investigating endometrial receptivity for completeness only. The mid-luteal endometrium was classified as good or bad based on the ring-type aspect of the glandular openings and the presence of well-developed varicose-like vessels during a hysteroscopic assessment. Only 4 small studies were conducted between 1992 and 2012, while their results do not support the hysteroscopic assessment of the endometrium to investigate endometrial receptivity. Here is a very brief summary of the presentation. There were over 50 markers of endometrial receptivity investigated. Some associations were identified between achieving a clinical pregnancy and endometrial thickness, endometrial pattern, tissue perfusion, and various molecules, which means they may be important for achieving a successful pregnancy. However, when we look at particular cutoffs to guide our clinical decisions in relation to performing an embryo transfer or not, none of the markers were able to accurately discriminate between success and failure. Some of the cutoffs, such as endometrial thickness of less than 6 millimeters, could be used as a marker of non-receptivity, but the incidence is so low that we rarely see it in clinics. Several complex molecular tests of endometrial receptivity have been developed on the assumption that embryos and endometrium may be out of sync, but the current evidence is not convincing for their large-scale use. The tests have a relatively large cost and may be impractical because they involve an endometrial biopsy which can't be performed during the IVF cycle. Having said that, the future is likely to rely on complex molecular tests of endometrial receptivity, but instead of endometrial biopsies, they will test the cervical or endometrial fluid aspirate to provide a point-of-care result within the IVF cycle. Here are a few references for further reading. You can come back to this list in the recording. Thank you for listening. I'm open to questions if you would like to ask.
Yeah, thank you for this overview. And we already have some questions. We start with the first one. The embryo grows in culture and that is hypoxia. So why do embryos need a highly vascular endometrium to grow?
That is a very good question. In the results from the meta-analysis actually showed that the endometrium itself doesn't have an increased vascularity. It's just the space beneath them. So probably that's the explanation, because it needs a hypoxic environment rather than hyperoxic.
Yeah, and we always have discussions, Laurentiu and I, about the uterine NK cells because we do not agree on this topic, as the audience might think. And the interesting thing about the UNK is that in animal models, it was shown that in case of higher uterine NKs, we have too much oxygen, so not the hypoxic state we want to have in the endometrium. I think this is also an interesting topic. But we go to the next question. I think Danilo is going to ask it.
Yeah, there's Yam. He was wondering if aspects of inflammatory endometrium is revealed by hysteroscopy. What would you suggest?
I can only say what the evidence so far says. There was no prospective study where a biopsy was taken, the inflammation was assessed and linked with future pregnancy. Most of the studies are in retrospective design, and that is biased, as I've explained, with the size of the uterus. The pregnancy itself will have some implication on how the endometrium looks after the pregnancy or after the miscarriage.
As Danilo and I are part of the Good Clinical Evidence guideline group of the ESHRE for recurrent implantation failure, we can fully agree that this is a problem. But as a clinician, we also can say it's quite difficult to convince patients to get an endometrial biopsy or whatever kind of testing before a pregnancy. It's a little bit like when you meet someone at a bar and you ask for the genetical background. You won't do this. So I think we have to work with the material or the tissue we are getting. And of course, there will always be a bias. And I think this was a nice discussion this morning also with Eva Hoffmann, that there's also some problems to link animal models to humans, but we have to do it because there are not that many other ways. So I go on with the next question.
I just 1 second. I completely agree on the difficulty of finding the samples. I'm just thinking about dozens of randomized trials that have done endometrial scratch before IVF. What happened to those samples? They could have been used so nicely for so much research on the content of the samples and then linked with the future outcome of the pregnancy following IVF, rather than just investigating the scratch as a procedure only. There are like thousands of samples.
I agree.
Definitely. And we hope that our PCC helps in getting collaborations with the colleagues having those samples. So we go on with the next question. It's about 3D ultrasound or 3D assessment of junctional zone and adenomyosis. I think this is a very interesting, quite new topic. Is it useful?
So there is evidence linking adenomyosis similar to endometriosis with poorer pregnancy outcomes, both in natural conceptions and IVF. But again, as investigated to be a marker of endometrial receptivity, there's no evidence prospectively. So I couldn't say if it is a strong enough marker to say not to do an embryo transfer or not. Probably it is not. So probably the outcome will be poorer, but not 100%. So you wouldn't decline a transfer based on the space there.
Yeah, as I mentioned before we started with the third session, we are having a large study on this topic right now. And I can only confirm that due to better ultrasounds, ultrasound machines or ultrasound options, we see differences in the myometrium or in the endometrium in patients with adenomyosis. And I think this is new for us, not really brand new, but quite new. And yeah, I'm looking forward to having studies with those subgroup of patients. Danilo, will you go on with the next question, please?
There is a question from Dr. Sakdeva that I found interesting in the list. You know, we are in the era of artificial intelligence and predictive algorithms. So she was wondering, or he was wondering whether, you know, isn't it better to have a combination of different molecular and ultrasound markers, you know, together in a same algorithm in order to attempt at predicting endometrial receptivity? I mean, what's your idea on this?
I strongly believe it's a very good idea. And it would work very well if you were to have an international database with multiple variables that could later on be analyzed by like machine learning or artificial intelligence. At the moment, it's so difficult to get enough numbers to have good precision and have reliable results to change clinical practice that we can't really rely on much.
Yeah.
I have a third comment, actually. You mentioned the quality and the design of the studies as well as the size of the studies, but you know there is another very huge confounder here, which is clearly an elephant in the room, that is the embryo, because not in all studies we are transferring embryos at the same stage. We are not aware of the. We have heard Eva this morning talking about aneuploidy, so we really don't know whether the embryos transferred were euploid or not. Maternal age and things like that obviously, you know, affect, in my view, any kind of marker, either, you know, molecular or not, of receptivity. I mean, what's your point on that?
I completely agree, and that's why when I mentioned the definition of endometrial receptivity, I said it's a very broad definition. It relies on the outcome of the pregnancy, if it's good or not. If it's good, it implies the receptivity was good. But if the outcome of the pregnancy is not good, it's not necessary because of lack of receptivity. It could be the embryo itself or the asynchrony between the embryo and the endometrium. So as long as we have no 100% test to test the quality of the endometrium, we'll never know much about the endometrium, really. That's why I think the future will rely on tests of non-receptivity, when to actually not to do the embryo transfer because you're sure the chance is so low, like the thickness of less than 6 millimeters.
And then, look, I think what we discussed in the group most recently, that it's also depending on the IVF center, what is done as a routine even before ART. I think this is also very important. Some do hysteroscopy with every patient before ART. Some do not consider it all. And I think these are major risk factors we are dealing with or not. And also in our study groups.
That's, that's a whole issue, the whole workup that has been done. And so whether, there are inclusion or exclusion criteria different from study to study. So there is another question that has been liked by 6 people by far from Dr. Vera Macianeni, who was asking your idea about endometrial microbiome that you didn't mention in the presentation, but it's a very hot topic currently. What's your take on that?
So our review was purely on clinical outcomes. So if there were no studies reporting clinical outcomes following testing of the endometrium by any means, then the study wasn't included. So we excluded all the basic research studies, so all the retrospective designs and the basic research. So all I can say, there was no prospective study looking at the microbiome and linking it prospectively with the fate of a pregnancy. The studies are mainly retrospective in design, where again, they had groups of women with failed reproduction, and they were compared with women who had successful pregnancies based on their endometrial microbiome. But again, you don't know if that microbiome is as such because of the pregnancy itself or the other way around.
Yeah.
So miscarriage is very likely to trigger inflammation in the endometrium. It associates endometritis. You get women with proper sepsis because of a miscarriage. So we can't ignore this bias of the retrospective design.
So I have, another question, because, this morning, Professor Brosens mentioned also the balance between receptivity and selectivity, and you focus mainly on receptivity. But what's your idea on, where one stands and the other one not? I mean, is it more important, the embryo, the endometrium? They are both important, the communication between the two. What is affecting what, in your view?
Obviously, they are both important. So, I don't think you can have a successful pregnancy with completely non-receptive endometrium. So, for instance, irrespective of the quality of the embryo, if you transfer it in a follicular phase sometime on, say, day 7, you will not achieve a pregnancy. It's very, very unlikely.
Yeah.
Same on the other way. If you have a very receptive endometrium and you transfer a completely aneuploid embryo, there will be no cells to lead to a normal pregnancy. The question is about mosaic embryos, where the theory of self-correction is still being investigated. And that is a potential news for the future, where an embryo that's not of such a good quality may lead to a normal pregnancy if it has good enough endometrium to develop into.
There's another question from the audience. Is there any data looking at resistant endometrium versus thin endometrium? I mean, is a thin endometrium a bigger problem if it's always thin in repeated cycles?
I'm not aware of such a study, so I can't comment on it.
Danilo, do you find any new questions? It's a problem because with the rating, the list changes every time.
There is actually a question that I found interesting. Dr. Vera Macianeni, he's wondering, isn't it a good embryo that makes the endometrium receptive? What do you think about that?
I completely agree. And this leads us to a slightly different topic, where we have published now 2 revisions of the same Cochrane review on intrauterine injection of HCG. So we know that embryos start releasing HCG even before reaching the endometrial cavity. So it is possible that there is a signaling between the embryo and the endometrium, where they talk to each other and they say, look, I'm coming, get ready to receive me and allow me to grow. And that's also based on the fact that we've seen this improvement in the pregnancy rates if the intrauterine HCG was given for cleavage stage embryos, but not for blastocyst stage, which could be explained by the fact that blastocyst stage embryos are already there and need quick implantation, while the cleavage stage could stay around for a little bit until the endometrium responds to the HCG and synchronizes with the presence of the cleavage stage embryo.
But just my curiosity, what about the other way around? An incompetent embryo, isn't there some message of incompetence that might say to the endometrium, be ready because I'm not good? Because, you know, that's part also of the theories of Professor Brosens.
Yeah.
Yes, so Professor Brosens has presented in a previous ESHRE meeting some very nice videos with endometrial cells and different quality embryos and how the endometrial cells respond to the signals from the embryo based on the quality. So yes, that is the basis of the selectivity theory.
I think I identified one new question. It's, what is your opinion on chronic endometritis defined by increased number of plasma cells in the endometrial biopsy? It's from Snajeke.
From what? Could you repeat the last part of the question? I didn't get.
I only tried to pronounce the name.
The name. Okay. So endometritis has been linked with poorer outcomes, again, retrospectively. So cohorts of women with different reproductive outcomes were compared based on their inflammation markers in the endometrium. So any association with poorer outcome is retrospective. So we don't know if the increased inflammation and endometritis is a second outcome because of the failed pregnancy or not. So what we need is a prospective study where we take a cohort of women, assess their chronic endometritis, and see what happens with the pregnancy.
And we need a standardized international test, whether we shall go for a chronic endometritis with one plasma cell or more. But nevertheless, I think especially the data from the Italian group in RIF patients showing a higher live birth rate after treating chronic endometritis with antibiotics is quite good. And of course, there are several studies showing nice data on recurrent miscarriage and recurrent implantation failure. Danilo, do you have further questions? Otherwise, we can think about having a short coffee break.
If you don't mind, I have one last question because, you know, Laurentiu mentioned ERA test and we know that several people are still doing it. So I was just wondering, what's your take on, you know, suggesting it on, not to the general population, but just to a selected population of maybe RIF or RPL patients? What's your idea on that?
I would like to see more evidence before suggesting it a large scale. So I think we are still at the stage where the company should prove the test works. So they should facilitate the development of such trials where the evidence of their tests could be shown, and then apply the test to routine clinical practice, even for a small group of RIF patients.
Thanks. So thank you again for this nice talk to both of you. I think
thank you for the questions.
Session, and I'm really looking forward for the next session where we going to discuss whether we shall do surgery or medical treatment in case of miscarriage, and I want to look on gestational trophoblastic tumors. So I hope everyone is having a nice coffee break, and we see each other in half an hour.
Thank you.